So I'd like to call on my co-principal investigator, Dr. Rosemary Frey from the School of Nursing, University of Auckland, to present some of the Ministry of Health survey completed prior to the implementation of the End-of-Life Choice Act. So, Rosemary?
Kia ora tātou. Ko Rosemary Frey tōku ingoa. Rosemary Frey, I'm a senior research fellow in the School of Nursing, and I'm doing two presentations today. The first is on New Zealand health professionals' knowledge and understanding of the Assisted Dying Act. So I'll start with a little background. As you're well aware, the Assisted Dying End-of-Life Choices Act came into force November 7, 2021, and is part of mainstream publicly funded healthcare. There are 3- and 5-year reviews of the Act. The 3rd-year review commences in November of this year. There were 2 workforce surveys commenced prior to implementation of the Act. First one was in February of 2021, and the second one was in July of 2021. So the aim of this first study is to explore the socio-demographic factors associated with health professionals' understanding of the End-of-Life Choices Act, support for assisted dying, and willingness to provide assisted dying. So I'll talk a little bit about the method. We did a secondary data analysis of the 2 workforce surveys that I talked about. Survey 1 had 1,980 participants and was launched in February, and Survey 2 had 859 participants in July 2021. Participants were medical practitioners, including psychiatrists, nurse practitioners, pharmacists, nurses, and allied health professionals. The data was collected using snowball sampling by distributing the surveys to a wide range of organizations, who were then asked to disseminate the invitation to their members. So that included district health boards at the time, hospices, medical colleges, Maori Health Services, associated organizations. So the first survey was open for 4 weeks, and the second survey was open for 3 weeks. Analyses that we used included descriptive statistics and inferential statistics, including chi-square and logistic regression. A little bit of information about the questionnaire. The questionnaire included 14 to 16 questions, respectively, and included a combination of yes/no answers, Likert scales, and free text answers. They also collected socio-demographic information on age, gender, ethnicity, health professional, what role they had, working setting, and location. The 2 surveys had different focus. First one was on attitudes. The second one was on training needs. Each questionnaire took approximately 10 minutes to complete. Moving on to the demographics. As I said, the first questionnaire had 1,980 responses. Most respondents were aged 45 years or above, female, European, and worked as medical practitioners and in a hospital setting. Survey 2 had about less than half of that number of responses, and notably had a higher number of nurses and nurse practitioners than in the first survey. Okay, moving on to some of the results. In terms of understanding of the Act, in Survey 1, 14.2% of health professionals reported having a very good understanding of the End-of-Life Choices Act, while 52.3% reported a good understanding. 31.8% reported limited understanding, and 1.7% had no understanding of the End-of-Life Choices Act. As you can see, Survey 2 had similar results. So what are the factors that underlie understanding? We found that health professionals aged 55 to 65 and over 65 were more likely to have a good or very good understanding of the End-of-Life Choices Act when compared to those under 35. In addition, health professionals working in a hospice were more likely to have a good or very good understanding of the Act compared to those in residential aged care. We found similar results in survey 2. Moving on to support for assisted dying. As you can see, 53% of the respondents in survey 1 were not in support of assisted dying, while nearly 47% were. But what factors underlie this? So, lower support was associated with being female, being a health professional from the South Island, and reporting Asian ethnicity or other ethnicity in compared to a European ethnicity. Factors associated with greater support, conversely, were being a nurse or reporting other health professions such as like physiotherapists, occupational therapists, psychologists. They were more likely to support assisted dying than medical practitioners. Willingness to provide assisted dying. Nearly 52% reported being unwilling to provide assisted dying services. Again, what were the factors involved? Similar to the support findings, women were less likely to be willing to provide assisted dying in comparison to men. In contrast, nurses, pharmacists, and other health professionals were more likely to be willing to provide assisted dying services than medical practitioners. So, a bit of discussion about what these results mean. In terms of those respondents who are older, having a greater understanding, it may be that they had more exposure to the issues over a longer period of time, and so therefore had greater understanding. In terms of support, the issues with gender, there have been other studies that have reported similar findings, finding men were more likely to support AD than women were. There's a study by Lau and colleagues in Hong Kong found male gender men had a relatively positive attitude towards euthanasia and assisted dying compared to females. This is the first study actually that has done research that focused on Asian health professionals' perspectives on assisted dying. There's very little international research on the issue. There's a study by in Hong Kong that found that male gender was, let's see, there's a study, not that study, sorry. There's a study, there's one study that found similar results with medical students, medical students at the Chinese University of Hong Kong, which found that 50% of first-year students supported euthanasia and assisted dying compared to 23% of fifth-year students. You have to note that assisted dying is illegal in Hong Kong, so as they get closer to graduation, they fell in line with what the rules are in that society. There may also be cultural factors that are involved. The End-of-Life Choices Act is very much an individual autonomy focused act. In Chinese society, there's less emphasis on individual rights and self-expression, more emphasis on community qualities such as harmony, function, and responsibility. Thus, healthcare decisions within Chinese culture may be more family-centered, with decisions made by the family as a group rather than as an individual. So that may be one factor that's involved. In terms of role, there have been other studies that have shown nurses are more likely to support assisted dying than physicians. However, the statutory and practice guidelines provide limited information on nurses' scope of practice regarding assisted dying. As Gary pointed out, only the role of attending nurse practitioners has been recognized, but they still can't assess eligibility. So we recommend New Zealand nurses, regulatory authorities, and professional representatives need to endorse policy statements ensuring practical and ethical support and sufficient protection regardless of their stance on assisted dying. In terms of pharmacists, under the End-of-Life Choices Act, pharmacists are involved in assisted dying services by dispensing lethal medication. As of this presentation, I only know of one pharmacy in New Zealand responsible for this role. We recommend that there should be more facilitation of involvement in care by pharmacists and nurses by reforming the practice and medication protocols along with professional development opportunities. If you want further details about this presentation, we have the article published in the New Zealand Journal of Medicine. Thank you.
Thank you, Rosemary. We've got time for a couple of questions. Have we got anyone? I'm just looking at the question and answer box there. There isn't any questions there.
Okay.
So perhaps we can continue with the second presentation, Rosemary.
Second presentation. Okay, moving on to the second presentation. Okay, the second presentation is about education and training needs for assisted dying. And a little bit of background, health professionals received 20-minute e-learning modules that covered an overview of the Act and assisted dying, key safeguards in the assisted dying process, and how assisted dying fits into existing health professional roles and responsibilities. Look most recently on the website, providers have been given 5 e-learning modules for medical and nurse practitioners who plan to provide assisted dying services. And as you can see, those are the topics that are covered. There've also been 5 webinars on assisted dying, and you can also see the topics covered for those. It's important to note, though, that at the time the surveys were done, only 1 e-learning module and 2 webinars were available to the health professionals. And since then, obviously, more has been provided. Okay. So the study aim is to explore whether online e-learning modules and webinars improved health professionals' understanding of the End-of-Life Choices Act. And just a reminder that this is a secondary data analysis. First survey, 1,980 in February, and survey 2, 859 respondents in July 2021. Again, same sample of participants, medical practitioners, nurse practitioners, pharmacists, nurses, and allied health professionals. Analyses were similar, including descriptive and inferential statistics. A reminder of the demographics. Most frequently between 45 and 55, most often female, and predominantly European and medical practitioners. So there are more nurses and more allied health professionals in the second survey compared to the first. Moving on to education. I wanted to note that this study marks the first national large-scale data gathered on New Zealand socio-demographic factors associated with health professionals' interest in this type of training. So, the online e-learning modules were completed by 200 people. The respondents were most frequently 55 to 65, female, identified as European, located on the North Island, and worked as medical practitioners in hospitals. 2 Maori and 2 Pacific health professionals completed the e-learning modules, whereas 10 Asian health professionals did. Webinars, 152 completed the webinars. They attended either 1 or 2 that were available. The largest group of these health professionals by category were female, aged 55 to 66, identified as European, located on the North Island, and worked as medical practitioners. So, what factors were involved in taking part in e-learning? There was a higher rate of e-learning module completion among health professionals over 45 years compared to those under 35 years. It suggests the necessity of targeting those health professionals who are most likely in their early career years and are less directly involved in assisted dying. It also noted that non-Europeans were less than half as likely to complete the e-learning modules. And interestingly, working in a hospice setting, they were more likely to complete the e-learning modules. Women were more likely to attend the webinars. But despite the low attendance of both training methods were associated with greater odds of understanding the Act. But more so for the e-learning module completion, health professionals more likely to have a good or very good understanding of the Act compared to those who had not. So it's over 8 times more likely to have a good or very good. In contrast, the overall understanding of the Act is 2 times higher in those who attended or watched at least one webinar. So our results do show a positive impact of the training on the understanding of the Act. So it's important to enhance training in providing health professionals with the means to increase their knowledge and competence in assisted dying. The questionnaire also asked what further information they requested. And these results are similar to those found and reported by the opinions of geriatricians in Australia and New Zealand, and in medical oncology groups in Australia. There's a desire of physicians for more training and clarity on assisted dying topics, such as boundaries of eligibility requirements, performing capacity assessment, and counseling patients requesting assisted dying. So the results are similar. I must report some of the limitations to both of the studies. One possible explanation for the low response was that the Act had only recently been legalized, and only 1 e-learning module and 2 webinars were available at the time that the survey was done. There was only a 3-week window for completion, which means that some of the responses were received prior to the mid-July webinar. And because the numbers were low, we didn't really get the chance to explore specific cultural needs. We also did not have access to the list of organizations that received the survey. And because there was snowball sampling, we were not able to calculate response rate. Content validity, we're unsure whether that was actually assessed or not, and if so, how. And it must also be noted, we're talking about understanding of the Act. This is a self-report measure. So because it's self-report, actual knowledge and understanding may differ from what someone reports. Finally, to some recommendations. Recommendations. Since assisted dying has implications for health professionals, there's a need for all health professionals to be familiar with the End-of-Life Choices Act and assisted dying services. Our study has highlighted that certain health professionals, specifically younger health professionals, could benefit from continuing medical education, continuing professional development. We also found you should consider enhancing the roles of nurses and pharmacists in caring for people requesting assisted dying. Given these groups we've shown are more likely to support AD and are willing to provide services. In terms of culture, data has shown that there is an interest in assisted dying among Maori. Of the 814 patients who applied for assisted dying between the 7th of November 2021 and 31 December 2022, there were 44 or 5.4% Maori and 3 from Pacific communities, indicating an interest in assisted dying among these groups. However, our results indicate a relatively low uptake of the e-learning modules and webinars attendance among Maori and Pacific health professionals. There's a need for further attempts to develop training that may, for example, include more include improved knowledge about tikanga and around the dying process and cultural support and guidance for patients requesting assisted dying and their whānau. And if you'd like further information about this paper, you can read all of the details in our article in the New Zealand Medical Journal.
Thank you, Rosemary. Now looking at again, we haven't had any questions. Just remind the audience, if you have any questions, please use the question and answer box. So a question, Rosemary, about the first presentation. Did any hospice staff show support for assisted dying?
We didn't break it down by location.
No. Yeah. We can go back to the data.
Yes, we can. Yes. We can, but we did not break it down by that.
Yeah. Another question, whether you know if the people who responded to the survey were more likely to have strong feelings about assisted dying compared to the larger health practitioner population.
Well, with any survey, there's always a self-selection bias. By the very nature of responding to the survey that shows an interest, but to be able to tell whether that's different than the larger population would have to have known what the population was, and we didn't have that data.
Okay, thank you, Rosemary. We'll move on to the next presentation.